Hi, everyone. Welcome to the VBC One studio. Really excited this week to have Joyce Go with Enable Dental in the studio. She is Chief Business Development Officer with Enable Dental. Hi, Joyce. How are you doing today?
Shannon, I'm doing good. Thanks for having me.
Fantastic. I came across Enable Dental when I was at a conference in Boston earlier this year and was really intrigued and thought what you guys were doing was so important to the Medicare Advantage community, to the entire healthcare community, actually. And so I would love you to start by talking a little bit about what Enable Dental does.
Sure. So, Enable Dental is a portable, and you'll hear me harp on portable instead of mobile because we're an at home, on site, comprehensive dental provider. So, we specialize in seniors and adults with disabilities, people who can't get out of their homes to go to a traditional dental setting. So, we go into the homes and deliver comprehensive dental care and serve as their dental home. Essentially, so we deliver exams and cleanings, but we can also do dentures, extractions, fillings, everything that they can get from a traditional office, we provide.
And why? And I realize that the answer is obvious, but would love for you to talk a little bit about why you felt that was important and really what went into the mission, into the work that you guys are doing.
I think there was widespread acceptance on a mobile capability, and we often get put in that bucket. But when you think about mobile, or what often happens is there's a lot of short term donated cleanings and screenings, potentially work that's done, and often nothing further than that. And there was a need to do more because there's nothing more frustrating than someone who needs an extraction, gets an exam, and is told you need an extraction, go get it elsewhere. And they already know that. And I think there was just not a modality that was appropriate for the homebound population where they can get recurring care and get to a state of maintenance rather than a state of just addressing acute needs.
So important and couldn't agree more as far as needing additional services. I've worked with a lot of patients and been a part of a lot of health fairs and just realizing that it's not so simple. It's not often just one thing, but that the challenges that they have are quite complex and
Mhm.
quite layered. And so great that you guys are providing that. Maybe too, and I've been in the healthcare space for a long time and have heard people even say, why are we providing all these benefits? When are we going to get back to just practicing medicine? Maybe you could talk a little bit about how you see or how Enable Dental, right, sees the connectedness between dental care and taking care of one's teeth related to their overall health. Because a lot of our listeners are concerned about, diabetes or cardiovascular disease in the aging population, or even maternal care with postpartum mothers, with pediatric care, making sure
Yeah.
patients are getting vaccinations. Why is it that you think dental care is important and how is it connected to healthcare?
Oftentimes, when you get comments such as, why are we providing all these services? What's the point of it? It's really deep and rooted in that we are payers or organizations have tight budgets. And so they have to prioritize what is most important. And sometimes dental is put in as elective. But I think there is a movement towards holistic, value-based, integrated care. And dental is more and more becoming accepted in that. So there is an impact on diabetes or heart disease, or much more simply, transportation and access to that. While you can think of us as just dental care, we can save on transportation, especially if you think about seniors who need dentures, where dentures take 4 to 6 visits. That's not including any type of adjustments. If you are an organization that's managing the entire care of that member or that patient, you are paying for transportation every single time for that. If you have overutilization of sedation for an IDD population, you are not only paying for dental, but you're actually dipping into medical costs to provide sedation when they might not need it. So I think there is a movement towards understanding how dental not only has a positive impact on things like diabetes, but where it can actually save on costs or logistics problems.
Important point. And also, too, we know that there's, and I'll just speak loosely about it, but we know that there's linkages between other conditions
Yeah.
and dental care, right? So, diabetes, you mentioned being one, cardiovascular disease. And so, making sure to focus on the whole patient. And then I would think there's that patient engagement aspect. So many questions that I could ask you. And
Yeah.
I'm not sure where to go next, but I was thinking, because we were talking about benefit design and you mentioned transportation, I'm sure on top of a lot of folks' minds are all the changes that have been going. We have one big beautiful bill that was just
Yep.
enacted. We
Yep.
have
Massive
rebate.
impact on Medicaid. Yep.
So would love to hear about how you guys are thinking about and how you're working with health plans and others. It would be good for, I think, you to talk about not only your customer, but then how you're working with those customers in order to continue to make sure that these benefits are part of that healthcare offering.
Sure. I think we work with organizations who serve some of the most expensive to care for populations. And so they're prior to even the big beautiful bill or any final rulings that have gone through recently, the premise of a lot of our partners was to integrate care in order to save on cost overall. So PACE programs are one of our partners. We partner with several of them across multiple states, and it mandates dental as a core service. And they receive a capitated arrangement, and we try to fit within the budgets of what's given to these organizations. So if they're capitated, we try to do something closer to value-based care. Medicare Advantage final ruling expanded flexibility around supplemental benefits, which makes it easier for MA plans to add on-site dental or a different modality. So I think part of the cost savings is understanding that if you have the right modality, you save in the long term.
Would agree with you. And I think that's long been an area we focused on risk adjustment for a long time. And I think because could see the remuneration that you would receive immediately, relatively immediately. You weren't waiting as long as, say, then quality scores. And so then
Right.
within the last few years, the conversation is, well, we have to make sure that we focus on health prevention, that we're keeping people healthier. And not that it wasn't looked at for a long time. I just think that getting our arms around it has been challenged, is that total cost of care element. And so how do we manage overall utilization and manage overall cost, and knowing
Mhm.
with the change of V28, a lot that is going on, that's necessary.
Yeah.
You mentioned that you work with PACE organizations. It would be great, because I'm not sure that our audience is fully aware. Maybe talk a little bit about what that is, and then also maybe take us through, because I know that's a particular type of population, but talk about the other types of patients that you guys provide services for.
Sure. So Enable Dental specifically serves two distinct populations, and that's all we serve all day, every day, which is seniors and adults with disabilities. Let's say our breakdown is about 85% seniors and 15% adults with disabilities. And it's a varying types where you can just put them in two buckets, but we deal with seniors in PACE, we have seniors in SNFs, but also if you further break that down to individuals that have dementia or Alzheimer's, and then you have IDD, and there's high functioning IDD and there's low functioning IDD, and it's a spectrum of individuals needing various types of care. But those are the two populations we generally serve. And then PACE is this incredible model of care, the program of all inclusive care for the elderly. It's an alternative to an individual getting just Medicaid or just Medicare. They opt into PACE. And what it is, think of like an adult day center, but in that they have your dentist, they have a podiatrist, they have your primary care physician, but you can also have activities there. They have meals there. Its goal is to ensure that their participants is what they call members in health plans, but in PACE, they're called participants. And PACE participants' goal is to keep them aging in the community and in the home, because we are about to go through a senior housing crisis here. We have the boomers about to retire, and there's not enough senior living facilities being built to catch up with that demand. And it's also very expensive to institutionalize seniors or populations. And so we are seeing a movement toward aging in place, and PACE, I think, is ahead of the curve with that, because they have a PACE center day. So in order to receive their care, and whether that's weekly, however many times a week, as part of their interdisciplinary team that determines that, which is incredible. And so that's where a lot of the integrated care actually happens. And the purpose of PACE, theory behind PACE, is that if you are integrating care and if you are having individuals age in place in their home and give them a sense of community while giving them the right care at the right time, then you actually save on Medicare and Medicaid costs for this population while improving outcomes. So for us, we work very closely being integrated with their IDT team, their interdisciplinary team, where they meet every day, they look at a patient holistically, and then from there you can customize treatment plans that's more appropriate for that patient.
I think that's so important to patient engagement. And then, like you said, being connected to the community. It's interesting that you brought up the housing crisis, because in all honesty, and maybe others have had this on their radar, but that was the first time that I've heard that. And it makes sense. People are living longer, not necessarily healthier, but they need a place
Right.
to go. And then we know, I think the dynamics around family support and caregivers is changing. And it's a really good point. And love what they're doing in those PACE organizations. Think that that wraparound support that they're providing is so important, especially
Oh,
when we
yeah.
think of having a tenable effect, if you will.
Yeah. And that's why the PACE model is growing so quickly. It's grown, I think,
Yes.
30% year over year, which is massive. And I think Nevada has decided to have PACE in their state, and more states, I think like Kentucky and Ohio, are now bringing the PACE model into their state because they realize there is a need for it.
So important. And again, I'm glad you brought that up, because I think that a lot of times in the work that we do, and I'm speaking the universal that we focus on Medicare Advantage, or we focus on
Yeah.
Medicaid. And there are other programs that are out there that we need to be aware of too. And yes, agree with you. It's growing by leaps and bounds. So definitely something to be aware of and potentially sponsor. You talked about IDD, and we know that there's been a lot of special needs plans of late that have been
Yeah.
developed. And interest, sharing something personally, I'm a mom of an IDD child.
Oh,
I
wow.
know that going to the dentist has been a challenge, and finding the right dentist. In fact, I actually take my son to my dentist. My children go to a pediatric dentist. I'm a mom
Wow.
of four. But I take my son to my dentist, and I just find the calming, kind of matter-of-fact way in which he handles patients works well with him. Interestingly enough, the pediatric dentist would do it, but not talk about maybe either how you're working with your staff as far as working with different populations, or even positive stories that you could share with that particular population and the services that you're providing.
Sure. We didn't start serving, we as an Enable Dental didn't start serving individuals with special needs until 2016 through waiver programs in Texas. Right now, we're one of the largest dental waiver program providers in Texas. So we see individuals in group homes, day habs, adult day centers, host homes, anywhere where they are. And what we have found over 9 years of serving the IDD population is that sedation is often overutilized. And then to your point about pediatric dentist versus your dentist, one of the things we do a great job at is hiring the right people. Not everyone can serve seniors or adults with disabilities, especially in a portable way. And so we're very intentional about the type of staff that we hire and bring into the homes. And we are part of our portable delivery model, not part of it is sedation. So we do not sedate given our model, but we do a lot of behavioral management and desensitization and care coordination with the caregivers to come at Maybe the mornings are better. Maybe the afternoons are better after lunch. Maybe we need a visit for them to meet the team first. Sometimes I've seen caregivers share pictures of the dentist and have sounds of the drill if we're about to do fillings. And one of the cool things that we do is, unlike a traditional office that has multi operatories, we only see one patient at a time and we're very low volume. We can go into the patient's home, take our time. If they need a break multiple times, great. If they can only get one filling done that day and they need four, we'll come back 4 times. And so one of my favorite stories was a mom who had multiple children, and it was always an ordeal to get all the kids into the car, go to the office, wait in a waiting room with with young children plus their IDD child. And they, and oftentimes here they need sedation. They go home, doesn't want to go through that entire process again. Patient never gets care. We go there and we're able to do the exam, cleaning some extractions, the fillings. And this took several visits over several weeks, and really understanding the patient and where the patient was most comfortable. And the mom and the children didn't have to leave the home. They were watching Netflix as their sibling was getting seen in their wheelchair or their recliner in the home. And it was really touching because we got the patient to a stable state where, instead of having these issues that are just unaddressed year over year, we addressed those acute issues, and now they're in health maintenance and just getting exams and cleanings the way you and I would be just getting exams and cleanings.
I can't even tell you. I can think back. My kids are older now, but he's 11. But I can think back to sitting in offices, sometimes 3 and 4 hours with 4 kids in
Yeah.
tow, trying to get services, and just how challenging that is. It's hard to keep kids on their best behavior, but to add that into the mix, and then hot, boring physician offices or
Yeah.
offices, very challenging. Yes. So glad those days are behind me.
Yeah.
What, again, so many places I think that we could go. Talk a little bit about, you talked about choosing the right staff, I think is important. Excuse me. Talk about the levels of practitioners. Who do you have? Is it hygienist? Is it dentist? What are the different specialties maybe that you have on the team that you have access to, that you can provide these services to patients?
Yeah. So we employ general dentists, hygienists, dental assistants, and we have dental managers. That is the clinical team that often goes out to homes and facilities. We don't employ specialists, so we have some very close partnerships depending on the types of payers or partners or patients that we serve across metro areas. But I call them super dentists, because our dentists that we hire, they do dental acrobatics. Oftentimes they're on their knees right next to someone's bed or their wheelchair, delivering the same type of care you would get in traditional office. And they love it. So I think part of the skill is one thing, the soft skill to be able to kindly and empathetically deliver care to this population is top of mind for us. And then just wanting to do as much as they can, because I think all of our providers understand that when you refer out, there's a high likelihood that they will not get the care. So they try to do as much as they can. So that's why we call them super dentists, because they're more likely to extract more. They do dentures more than a traditional office, where seniors might not be a good portion of your patient population. And so tons of dentures, tons of extraction, a lot of behavioral management going on with our providers, but they are all general dentists that have either had hospital dental experience, some special needs dental, maybe a GPR or a residency, but there are no specialists on our team currently, which is, I think, pretty cool that we're able to deliver so many services to an in-need population without needing specialist care or some of the most expensive care.
I've been doing a study interviewing physicians, and I would imagine then that this applies to dentists as well. One of the things that they talk about is that very much a part of the passion is that they went to medical school and obviously endured everything that they did because they wanted to help people.
Yeah.
And it sounds like that helps solve for that. Are your dentists, are they working with you 100%? Like that they're a full-time employee? And I'm just thinking if there's any dentists out there that might be interested in participating in this type of work,
Oh yeah,
how connected
it's
with you?
yeah, absolutely. We're always looking for providers. We're growing rapidly as a company. We have more and more partnerships. We're expanding to other states. So if you're a provider listening to this, please reach out. And it's not all full time, it's a mix. We have some providers who just finished their residency, tried their hand in maybe corporate dental, and really wanted to have something maybe more meaningful and wanted to feel like they were helping. So they might be working with us full time. Other providers have their own practice, maybe work there 3 or 4 days a week and work with us 1 or 2 days a week. And some providers sold their practice but still want to do some and give back to the community 1 or 2 days a week. So it really does vary. You don't have to work with us full time. You can work with us 1 day a week. You can, and we have some providers who flux. Some of them who have started with us full time, then move to buy their own practice and still stay with us once in a while, which is great too. We're pretty flexible.
Awesome. And then you mentioned about states, and there's been a lot of focus even recently in the news on rural healthcare. How are you? Where are you located? Are you all 50 states? Are there certain geographies? And then how are you balancing needs we see between, say, urban areas and then those that are suburban or even rural?
Sure. So we are right now in 11 states and 28 markets. Our intention is to be in the top 50 metro areas in the next few years. That's Washington, California, Colorado, Kansas, Missouri, Texas, Florida, Pennsylvania, Massachusetts, Michigan, and New York. I may have
Wow.
missed one, but those are the states right now. And then as it relates to urban versus rural, it's pretty interesting because people have very different definitions of rural. And we serve a 90 to 100 mile radius from any metro area. So when we say we serve Dallas, Texas, for example, what we really mean is we serve a 90-mile radius from that metro area. So that can reach rural areas, especially as we're talking about smaller states like New York, and it's pretty big, but Massachusetts, that are smaller East Coast states, we're able to reach a lot more rural areas. Now, when you're talking about Texas, you drive an hour and you're still in the same city. Oftentimes, the same thing with California, but we are capable of seeing some rural areas. But what I tell a lot of partners is if you have a rural area and you have a payment model or mechanism to support the care for these populations in these rural areas, we are able to be there.
That's fantastic. I laughed when you said about small states. I grew up in New York and to drive 100 miles, you'd be through 5 states.
Yeah,
And then
exactly. Go to Pennsylvania and all that. Yeah. And Texas, you drive five
we're
hours and
still in Texas.
you drive 10
Yeah,
hours and still be in Texas.
yeah, it's a big state. Everything is big in Texas.
Yeah.
And so one of the other questions that I wanted to make sure to ask you too is how do patients receive you with you going into the home? Is this something that is unfamiliar to them or it has become an expectation? I'm just curious because folks are usually, when they think of having to see their physicians, and maybe COVID changed some of this, you had to go out, you had to go to the centers, you had
Yeah.
to go to the hospital, or you have to go to the dentist office. To have someone come to the home was a lost art. And so curious
Yeah.
to how patients feel with you coming to the home and then doing that work. There's an aspect of cleanliness and being able to maintain a clean and sterile environment. So talk to me a little bit about that, about the different aspects of how you're received by the patient at the home.
Sure. So it's interesting that you bring up COVID because there has been a pretty significant mindset or a change post COVID about bringing at home care to these populations. So pre COVID, you're absolutely correct. There was always a concern about, is it safe? Is it thorough? Is it as comprehensive? And the answer to that is we are still governed by the same bodies, OSHA, ADA, as traditional dental office. So we do get audited in very much the same way to ensure that there's cleanliness, that we're sterilizing instruments, same time and at the highest quality way. We're still held by the same standards. And I think it's difficult for people to understand that because we are at home or mobile. And post pandemic, because we dealt with frail populations, all of the ecosystem that dealt with delivering care to this population had to suddenly bring care on site. So I think from a patient standpoint, seniors who are institutionalized often have a lot of care. They have caregivers, they have nurses. There's always care being brought to them. So we were no different, aside from that we were looking in the mouth. So we were generally very well received. I would say the IDD population, a little bit different, that we had to incorporate a few different techniques, if you will, to ensure that the patient got desensitized or that the patient was comfortable seeing us there. Because oftentimes they went to a pediatric dentist and then got sedated. So they never had to interact meaningfully with a provider. And COVID changed that, and we don't sedate. And I think there has been an identification of overutilization of sedation in the IDD population. So now these individuals are receiving care in their mouth in their home. I would say for that population, we've had to work very closely with caregivers who are an incredibly important component to delivering quality care to them. So educating the caregivers, preparing the caregivers and families was a big part of how we ensured that we had a successful visit for this population.
I literally, it's come up now a couple of times. I interviewed a neuroscientist from another company just the other day, and Creos, so I'll give them a plug, and Dr. Adrian Owen, very fascinating, but he talked about too how they've noticed effects, and I don't want to misstate anything, but they noticed effects with anesthesia and effects on the brain. So it
Yeah.
makes me think, especially with that population being as vulnerable as they are, and then over sedating them, the other types of effects, right? That could be there that maybe we know, or maybe we don't. As a mom of, like I said, a child of IDD, not something that I necessarily thought about, but I'll
Mhm.
definitely think about going forward. So good to know.
Yeah, there is not necessarily with IDD to your point, but for patients with dementia, because that's how it
Yes.
started. Enable Dental started serving memory care facilities early on. And there is this fear, rightfully, of the patient being different and not being able to recover from a mental standpoint after receiving sedation. So just not doing sedation on such a frail population that is often disoriented and where familiarity is very important. Moving away from sedation has a huge impact on that population. And I'm sure there is as well for IDD.
Wow. Tell us about who your typical clients are and how you engage with them. Is it health plans? Is it medical groups? So, how are you getting out there in this space? And I know you said you work with PACE organizations, but how do you get out there in this space and let folks know about what you're doing and then have contracts with them so that you can go out and provide these services? What does that look like?
There's a top down and there's also a bottom up approach. It's not uncommon for our teams to be out in the facilities and you'll have an Optum nurse or someone who works at a health plan or a family member say, my mom needs care. Do you take X insurance? Or they end up calling their payer or plan wanting to know if we are a capability. And then the plan can reach out to us. That has happened. And then from a top down approach, very similar to the way I met you, their conferences are huge. And a lot of people don't know that this capability exists, much less people know that there's a mobile dentist, right? People know that you can get cleanings and exams. But what people don't know is that there is a company that exists that specializes in seniors and adults with disabilities and can provide comprehensive care. And that's actually where I think we differentiate ourselves. Sometimes it's just introductions and meeting with people who want to innovate their plans. And we're used sometimes as a customer acquisition and retention tool. And sometimes we're used for quality and other times we're used for utilization. And so it just depends on the need of the plan. And I say plan very broadly to mean we work with MCOs. We work with IDD waiver programs. We work with fully integrated dual advantage plans, lots of care coordination organizations that also so happen to be payers, area agencies on aging, really any group that serves seniors and adults with disabilities, or a group that has a population that cannot get to the dentist. Jails have reached out to us, jail systems, saying similar issues as I can't get patients to get dental care. We've worked with various groups.
So it sounds like you're flexible in getting out there and seeing patients. There's lots of flexible ways that someone who's interested in the services could use you too. Okay. Tell me, maybe share with us. I know you told the story about the mom and some of the work the dentists were doing of getting on the floor and next to the bed or the wheelchair. Any like positive stories, patient stories that you could share where you were able to provide care that maybe was in an unusual circumstance or a challenge that you were able to overcome for that patient and provide them with the care that they needed?
Man, there are so many. We could tell more than one. There are stories. My role in this company has evolved over time. I used to actually dental assist and
Wow.
help. We were a very small company. I used to do the marketing and the sales, and I was a dental assistant, and I would do all of that. I could take x-rays. And I remember we had a family that was worried about mom isolating herself. And we just so happened to go to that facility, and they said, mom doesn't really have any problems, but just know that she doesn't like to really see people. And if you can see her in her room, that would be great. So we go in, the patient had some broken teeth. We did some extractions and we provided dentures for this patient who was friendly, but again, identified or marked as isolating herself. And after we delivered dentures, I remember we come back to the facilities frequently, depending on what patients or residents need. I remember passing by, I was lugging all of our equipment, and this patient was playing bingo and eating ice cream out in the common area of the memory care area, which was amazing. And so I think we forget that. I hear a lot, oh, she's not in pain or she's not complaining, that there is dignity and then there is shame that's associated with not having teeth and or having bad oral care that can impact social interactions that are so very important for populations very prone to isolation, such as seniors. And that's a huge impact. And so just seeing her happy, even though for weeks or months, the family thought she just doesn't like to deal with people. It was just not true. Just wanted teeth and wanted to be able to eat in order to enjoy what was going on with all the activities in the facility, which was great.
I love that story. And I think it just highlights the important work that you're doing and agree with you. You know, sometimes we're not aware. We think it's one reason, it's something else. And so you really have an impact and change someone's life
Mhm.
entirely for the good. And just thinking the impact too for the family
Yeah.
relationships there. Excellent. Is there anything that we haven't talked about today that you would like to make sure that the audience is aware of about you and about Enabled Dental?
Oh man. I think there is a common misconception about insurance coverage as it relates to receiving a portable or at-home care. So most families, when they hear about our services, think that you have to be part of traditional commercial insurance to partake in our services. But you also have to remember that dental insurance is an employee benefit. Our median patient age for a very long time was 87 years old. Most of our patients are not employees, nor do they receive employee benefits. So we're actually the opposite. Given the populations that we serve, we are part of waiver programs, innovative Medicare Advantage plans. There are so many programs out there that's made for HCBS or home and community-based services that we partake in. And people don't know that even if we are not part of it, we are happy to try and be part of it because sometimes we just don't know. PACE, we learned about a few years ago, right? IDD waiver programs, unless you know about HCS or ICF or class programs in Texas, you would never know. And sometimes those programs don't know that we exist either. So sometimes those connections alone are just letting us know, hey, I don't have commercial insurance, but this is my child is part of this waiver program, can be pretty meaningful because then we can reach out and try to figure out some type of single case agreement in the worst case scenario. So we don't just say, sorry, not in network, can't help you. And I think you just hear that so much in healthcare. There's in-network versus out-of-network and out-of-pocket costs when we know the population we serve often can't afford expensive dental care. So we try very hard to figure out models that they're in or programs that they're in and work with them.
I'm hoping, and even as we've been filming, hoping that someone hears, it goes out on LinkedIn. It also goes out on YouTube that, someone that either an executive that wants to offer these services to patients and recognizes that need, or even a practitioner or a patient themselves that is in need of those services,
Mhm.
practitioner that knows a patient that's in need of those services. I hope they hear and they recognize that this is available to them. And again, I think you guys are doing amazing work, and knew when I met you in Boston that I needed to have you.
Thank you.
I've worked in the industry for more than 20 years and go to a lot of conferences. And it was one of the first. I know that there's other companies too, but it just wasn't something that was top of mind for me, and thought it was important that we share it with our community
Yeah,
and
of
that that's available. So thank you so much.
course. Thank you for having me.
Absolutely. Is there anything else that you want to say? I
You
can
know,
edit.
I really do think that something that's not spoken about, if there are any legislators or people or lobbyists that are part of reform as it relates to coverage and types of care available to seniors and adults with disabilities, there's a misconception that there are no dentists or lack of providers who serve this population. And it's just not true. And I know this because we have providers that we pay well because we have partners that invest in solving a problem. But when you say there are no dentists, there's a systemic issue where we're expecting providers to essentially donate their time and resources to accept the bottom of the barrel Medicaid fees that are not sustainable to serve those populations. We could go on and on, probably spend another hour on reimbursement rates and how that impacts providers. But I think there are any type of lobbyist or anyone who has the ability to impact that. We need to consider that investing in a different type of payment model for these individuals. I understand that there's cost savings that we have to do, but you can save on costs by investing ahead of time and having the coverage to do so.
We can talk about that. We have probably, I was going to say, we have 15 minutes left.
Yeah.
We can really talk about that. And then there's been a lot, right? There's been a lot that's been introduced just in the last month or so. I think
Yeah.
that has an impact, especially on this segment. So would love to have you talk, pontificate, maybe about, I was going to actually ask you that question. What in the future, like reading the tea leaves, and then recommendations that you might have either to continue what you're doing, or maybe there's legislation out there or things that need to be done to change what you're doing in a positive way because of the experience that you have today.
Yeah. I
So
think new legislation that has to come out needs to incentivize providers. And I'm not just talking increased fees, it's actually much more complicated than that. It needs to incentivize and align medical and dental and all other providers with the same goal. I personally don't like the fee for service model as it relates to dental, because that's what you're incentivizing. You're incentivizing the more you code, the more you get paid. And that is completely misaligned with how payers or plans are incentivized by CMS to share in cost savings of outcomes. Now, that is a criticism of our existing legislation, but from a dental or provider standpoint, we can get better because we say there's an impact to overall health, but what are we really doing to measure that? Everyone can agree to that, right? We all know the mouth connected to the body, fine, but how do we quantify that? And the issue with that is we are so different in just even coding and tracking what we do. So you have medical that does ICD-10 coding and dental that does ADA CDT codes. How in the world we can't even talk to each other? And that is a problem. I can't tell you that I have that to share in your cost savings on diabetes when you can't track what component of that I have actually impacted as a dental provider. And that's a problem. No one really knows how to do value-based dental and it's entire, like we try as Enable that we talk about NPS scores and utilization, we care about satisfaction, but from a true clinical, as you like dive deep into what is actually measured in medical, you can't do it in dental. And that issue goes into dental schools, into the ADA, into how we function as dental providers and how we code. There is no diagnostic codes, there are treatment codes.
Where would you say, and I'm assuming in addition to that, if you wave your magic wand, what would be maybe 3 changes that you would make in order to improve those challenges, that lack of communication, or something else if you wanted to pick? But
I mean, wave a magic wand, all dental schools teach the future dentists how to ICD-10 code and that our claims forms match that and that you have plans that are able to connect dental to things like hospital visits and diabetes management and heart disease. Easier said than done is a reason why it doesn't really exist. But
an encounter in the claim to be accurate.
yeah, exactly. Right? We're still working on accurate encounters and claims. So that is, like you said, a wave of magic wand, what could be happening. But I do know that, and I guess I'll do a few plugs, that Mary Foley, part of CMS, is working with NYU, which graduates 10%. It's one of our largest dental schools and graduates 10% of dentists that work in the United States. They are starting to teach students how to do ICD-10 coding and really think of, yes, exactly, and think of the patient holistically, and where our data starts to integrate and starts to talk to each other. So I know there's movement there for that. It's not in every dental school, but I do know that there is a general awareness of this problem because we can't just keep increasing rates everywhere, right? That's just not tenable, especially when we have more and more people living longer and, to your point earlier, unhealthier. But what we can do is identify some of the most costly things on the medical side and see where specialists or specialist partners such as Enable Dental can impact that. So dental might be a little bit more expensive, but sedation is lower. Diabetes is better managed and you're saving thousands of dollars there to spend a couple of hundred in dental. So that is the wave of magic wand thing. And I think there is a movement towards that, which I'm very grateful for and that we're in the early stages of.
That's fantastic. I hadn't heard of that. And I know it's amazing to me. Just even, I'm thinking I was at a value-based care conference a couple of years ago now, and we had representation from the government, from the federal government there. And they spoke. And we're making all these changes. We're making all these requirements. We're putting pressure on physicians for performance and on their payments. And then you mentioned about the health plans and how everything's about driving outcomes. But yet, interoperability is still this El Dorado that no one's managed to get to. And I spoke specifically about dentists, but it exists all over healthcare.
Yeah.
It's amazing to me. That's a challenge when there's so many other things that we're trying to solve. And we've come up with great solutions and all the developments, even in medicine itself. And we can't figure that out. It just doesn't make sense.
We can do AI. Surely AI can solve this for us, right?
Yes. I love AI.
Yeah.
I'd agree. Yeah. Just that we don't have that yet. It makes you think that. I don't know that it's not, the ability's not there, right? I would suspect in my naive way, there are other barriers or challenges.
Oh yeah.
To that being something that was realized today. But
yeah. The model and the delivery model is really interesting, but the larger impact is, at least for Enable Dental, is to be part of that value, that change towards holistic value-based care. So thank you for letting me mention at least that component of it.
I thought it was fantastic, and I know our audience will too. I want to thank you again for being, really appreciate it.
Always happy to do this.